Good morning. Let us come back to our previous discussion. The last of the protein synthesis inhibitors, macrolides. The term macrolide means a multi-membered lactone ring structure in which one or more deoxysugar molecules are attached. The prototype macrolide is erythromycin, which has a 14-member lactone ring attached with two deoxysugar moieties and is derived from Streptomyces erythraeus. Beside this, there are some other drugs like Roxythromycin, Clarithromycin, Azithromycin, and Fidaxomicin. Fidaxomicin needs a little bit of introduction. It's a narrow spectrum macrolide which is minimally absorbed on oral administration. It inhibits bacterial RNA polymerase and is bactericidal in nature. Rest of the macrolides are basically static in nature in normal therapeutic concentration. But in more than therapeutic concentration, but it is within tolerable limit, it can be useful as a cidal preparation. Macrolides are derived from Streptomyces erythraeus and it was discovered by McGurr and its co-workers in 1952. Later on, Clarithromycin, Azithromycin and Roxythromycin developed with its derivatives of erythromycin in a slightly modified spectrum of antibacterial activity. Fidaxomicin is not only having bactericidal activity, but it is also a kind of semi-synthetic macrolide. Beside these macrolides, there are some lincosamides. Lincosamides are lincomycin and clindamycin. They are almost having similar kind of mechanism of action, but they are belonging to different groups. Similarly, we are getting one ketolide known as Telethromycin. This Telethromycin is the first ketolide antibiotic related to erythromycin with similar antibacterial spectrum, and it is effective against macrolide resistant pneumococci. So from the first slide we know there are groups like macrolides, ketolide and lincosamide. There is a group, last group of protein synthesis inhibitor, that is macrolide, and macrolide consists of erythromycin, roxythromycin, azithromycin, clarithromycin and fidaxomicin. Next slide please. The mechanism of macrolides is based on its inhibitory property on the protein synthesis by binding reversibly to peptidyl site of 50S ribosomal subunit of the bacteria. Precisely, these drugs inhibit the translocation step, wherein this tRNA with its growing peptide chain is translocated, that means shifted from the acceptor site to the peptidyl site. As a result, the ribosome cannot move on one codon further towards right, and it is relative to mRNA. In other words, acceptor site does not become free to accept the next incoming tRNA charged with desired amino acid. The protein synthesis hence stops, and macrolides do not inhibit the 60S or 40S ribosomal unit of the mammalian cells. Hence, these drugs are not permeate through mitochondrial membrane of the host cells, and therefore the chance of toxicity is far lesser in comparison to any other antibiotic in case of macrolides. So it's a comparatively safe group of antibiotic which we can use as a first line drug in different situations or as an alternative to beta lactam antibiotic. Antimicrobial activity of macrolides is enhanced by alkaline pH because these are weakly basic drugs, and increased pH results in more of the unionized form of the drug for penetration into the bacterial cell. These drugs are effective against aerobic gram-positive cocci that includes Streptococcus pyogenes, Streptococcus pneumoniae, Streptococcus viridans, usually with a minimum inhibitory concentration of around 0.015 to 2 microgram per ml in the plasma. Staphylococci, Haemophilus influenzae, Neisseria meningitis, Neisseria gonorrhoeae are moderately sensitive to this macrolide. The gram-positive bacilli that are sensitive to macrolides include Clostridium perfringens, Corynebacterium diphtheria, and Listeria monocytogenes. The other organisms which are sensitive to erythromycin are Mycoplasma pneumoniae, Legionella pneumophilia, Chlamydia, Rickettsia, but obviously the action of clarithromycin and azithromycin is better on these kind of organisms. Clarithromycin is little more potent than erythromycin against sensitive strains of streptococci and staphylococci. It has moderate activity against Neisseria gonorrhoeae and Haemophilus influenzae. But clarithromycin is a drug which can be useful in peptic ulcer associated with H. pylori infection. So its effectiveness against H. pylori is unique among this group of drugs. Azithromycin is less active than erythromycin and clarithromycin against streptococci and staphylococci, but it's more active against Haemophilus influenzae, Chlamydia, Mycoplasma, C. jejuni, Fusobacterium, Salmonella, that means in typhoid fever, Neisseria gonorrhoeae. So in all these cases we are seeing a better role of azithromycin. Whereas roxythromycin is not a FDA approved drug, but still in India this one is used, and it has a typical pharmacokinetics that its relationship with food is obvious. So you have to prescribe this oxythromycin formation before food, and the antibacterial activity of roxythromycin is similar to that of erythromycin. It is particularly effective against streptopneumoniae, streptopyogenes, Mycoplasma pneumoniae, and the chlamydia species. Fidaxomicin, which is a bactericidal one, is active against Clostridium difficile and has no action against other organisms. It is poorly absorbed when given orally and available for oral use for therapy of Clostridium difficile infection. So, macrolides are basically of two types: the static one, and the main four drugs, erythromycin, azithromycin, clarithromycin, and roxythromycin, are bacteriostatic in action, whereas fidaxomicin is having cidal action. Out of the first four drugs, roxythromycin is not a FDA approved drug. Hence, you will not see this name roxythromycin in Goodman-Gilman. Next one, please. The chance of bacterial resistance is quite common with even this drug, It starts with impaired permeability of the antibiotic through the bacterial cell membrane. The same mechanism of efflux of the drug by an active transport mechanism or drug vomiting is also existing in case of this drug. Protection of the ribosomal subunit against the action of macrolide by the constitutive and inducible methylase enzyme which prevent the binding of macrolide to the ribosomal subunit. This is basically the mechanism by which resistance may develop. A mutation, basically the chromosomal mutation is pretty common with this group of drug. It consists of 50S ribosomal subunit. Formation of macrolide inactivating enzymes, that is esterases, produced by Enterobacteriaceae which hydrolyze macrolides are also not very uncommon. The next one, please. So the group of drugs which you have to remember from the group of macrolides are erythromycin, roxythromycin, azithromycin, and clarithromycin. All these four groups of drugs are basically bacteriostatic drug. Erythromycin free base is destroyed by gastric acid and therefore administered orally with an enteric coating that dissolves in duodenum. Food interferes with its absorption. Ester forms, that is stearate or ethyl succinate or its ester salts like erythromycin estolate are available to overcome this problem, and this will protect it from acid degradation. Erythromycin lactobionate, the water soluble salt of the drug, is available for intravenous administration. Usually intramuscular injections are extremely painful, hence all these kind of probable administration, route of administration is avoided in patients. Erythromycin estolate is the best absorbed oral preparation that can be taken without any regard to meals, but it has its own adverse drug reactions, and that I will discuss in the later slides. Erythromycin is well distributed. It produces therapeutic concentrations in tonsillar tissues, middle ear, high concentration in alveolar macrophages and neutrophils. ECSF levels comes around 15 to 20% of the plasma level. It can be metabolized by liver and primarily excreted through bile and lost in feces. Whereas roxythromycin is a semi-synthetic derivative of erythromycin. It is a long-acting preparation. So the dose in case of erythromycin is 250 mg 4 times daily, whereas in case of roxythromycin, it is 150 mg twice daily, 1 hour or half an hour before food. It's an acid-stable macrolide, but interaction with food is common. Longer half-life makes it suitable for twice daily application. Clarithromycin is an O-methyl derivative of erythromycin. It's also an acid-stable macrolide. Food does not interfere with its oral absorption. Its longer half-life, T-half of around 6 to 7 hours, also permits twice daily dosing. So patient compliance is going to be better with clarithromycin. It is metabolized in liver to 14-hydroxy clarithromycin, which also has good antimicrobial activity. The drug and its metabolites are excreted via kidney. Dosing adjustments are needed in patients with compromised renal functions. So this one is probably not undergoing that much in enterohepatic circulation. The last one is basically azithromycin, which is basically a 5th generation macrolide, and it's more acid stable with wider tissue distribution except CSF. Therapeutic concentrations are achieved in lung, genital tissue, liver, prostate, and also in phagocytes, so which has a clinical importance. Macrophages and fibroblasts, from where it is slowly released. So, azithromycin is stored in phagocytes, macrophage, and fibroblasts, from where it is slowly released, and hence its elimination half life is about 68 hours. And that once daily formulation of azithromycin is basically shortening the duration of treatment for 3 to 5 days or 6 days. And once daily formulation is possible because of this reason. Food interfere with its absorption. It can be taken 1 hour before or 2 hour after meals. It does not inhibit cytochrome P450 enzymes like its previous one, erythromycin. So liver enzymes are unaffected with azithromycin. It is largely excreted unchanged in the bile. Renal excretion is only 5 to 10%, and it has a significant post antibiotic effect. So this group of drugs has a significant post antibiotic effect which is not seen in case of other macrolides. So just to recapitulate few of the important uh, pharmacokinetic properties of these drugs. Erythromycin estrolate is acid stable and it is given at a dose of 250 milligram 4 times daily formulation, which has some kind of little bit of side effect like cholestasis, which may lead to jaundice later on, but it is lesser in comparison to the other preparations. It is probably the best possible oral preparations we have in our hand, whereas erythromycin lactobionate can be given in injectable form, but ideally via intravenous route. Intramuscular injection is extremely painful, hence we are avoiding this route. Clarithromycin absorbed rapidly from the GI tract, but its half-life is around 6 to 7 hours, hence it's one of the best preparations we have in our hand. This is given in case of community acquired pneumonia as well as in case of H. pylori associated peptic ulcer, where other macrolide group of antibiotics are not that effective, though azithromycin is almost similarly work in case of community acquired pneumonia. Macrolides cannot cross blood-brain barrier even in meningitis, and only 10 to 15% of its concentration reaches CSF. Plasma concentration reaches CSF. Hence, we are actually avoiding these kind of formulations in meningitis. Azithromycin is found in higher concentration in phagocyte, macrophage, and fibroblast. It's almost the action lasts for 64 hours. So this is its half-life. Hence, once daily formulation is good enough, and it has a very good post-antibiotic effect. So azithromycin has a one of the best possible post-antibiotic effect, and hence these type of antibiotics can be prescribed in case of where the plasma concentration or the drug is working even below MIC level. So basically, the agents that show time dependent killing and having prolonged post antibiotic effects are azithromycin and clarithromycin. Now, for azithromycin, the duration of antibacterial exposure is important. Its clinical effectiveness is not compromised. If their concentration falls below the MIC and MBC, they possess longer and persistent post-antibiotic effect. Even azithromycin can be prescribed at a dose of 1 gram once daily formulation for 5 days in case of typhoid fever. Initially, it was prescribed in case of NARST variety, that means nalidixic acid resistant typhoid fever variety or Salmonella typhi variety. But nowadays, even azithromycin can be prescribed with any one of the first line drug in case of typhoid fever. So the next one, please. So these are the common clinical uses of macrolide group of antibiotic as a whole. It starts with diphtheria. Though we know that diphtheria itself requires antitoxin, but erythromycin is probably the most effective antibiotic in treating acute infective stage of diphtheria and for eradicating the carrier state through the course of acute infection cannot be prevented, for which, as I said, antidiphtheritic serum must be administered. So, in treatment of diphtheria should be antidiphtheritic serum and erythromycin as a first choice antibiotic, 250 mg 4 times a day for 7 days. This group of drug, erythromycin and azithromycin, are your drug of choice in case of rapid control in pertussis, which is caused by Bordetella pertussis, and it is also used as a prophylactic agent for preventing the spread during post-exposure period in the community. A 7-day treatment with erythromycin estrolate is effective in most cases of pertussis. The dose is around 40 mg per kg per day. So it is again probably coming around 250 mg 4 times daily. Macrolide group can be your first choice in case of community acquired pneumonia. Usually we select 1 or 2 of the antibiotic from the main 3 groups. The main 3 groups are beta-lactam group of antibiotic, which includes penicillin and cephalosporin. The second group is the macrolide group of antibiotic, which includes azithromycin, clarithromycin, even sometimes erythromycin. And the third group is the fluoroquinolones, which includes ciprofloxacin, levofloxacin, this kind of preparations. So most of the times, if we suspect drug resistance or in case of empirical therapy, we combine any 2 of the groups. Chlamydial infection and STDs. So macrolides are very effective in treating those things. Uncomplicated urethral, endocervical, rectal, epididymal, respiratory, neonatal, ocular chlamydial infections caused by Chlamydia trachomatis can be easily controlled with this group of drug. A single dose of 1 gram azithromycin has been found to provide complete cure for urogenital chlamydial infections. Also, in case of gonorrhea, it is combined with ceftriaxone, 250 mg single dose, and this combination will give you a complete cure. Azithromycin 1 gram a week for 3 weeks is highly effective in treating lymphogranuloma venereum, which is basically the answer of your case study in the presentation of tetracycline and chloramphenicol. So, doxycycline or tetracycline can be replaced with azithromycin, where you cannot prescribe doxycycline to few patients, and this one is having lesser toxicity. And patient compliance is also better, as a single oral dose of 1 gram is highly effective in curing Haemophilus ducrei infection, which is also known as chancroid. So again, repeating pertussis, it is not only used as a treatment of cure, but it is also useful as a prophylactic therapy. It can replace penicillin for the prophylaxis of infective endocarditis, but if you want to add some kind of gram-negative some agents which will tackle gram-negative infections. It's better to add gentamicin or amikacin, that means aminoglycoside group of drug, in thrice daily dose regime. And this type of prophylactic agent is usually used during dental procedures, usually 2 hours before dental therapy, or it should be continued for 3 days, and you should, after that you may go for dental extraction. In case of tetanus, where you don't have the option of giving penicillin due to some allergic reactions or hypersensitivity reaction, you can always select macrolide group of antibiotic. As a prophylaxis in case of mycobacterial infection, that is disseminated Macrobacterium avium complex MAC disease in persons with advanced HIV infection, this drug is recommended as a 1200 milligram once weekly dose. This one can also be given in H. pylori infection in peptic ulcer, and that drug is very specific. It is clarithromycin. None of the other agents are that effective against H. pylori infection. In toxoplasmosis, you can prescribe azithromycin. You can prescribe it in case of pelvic inflammatory diseases, and in case of Clostridium difficile infection, you may prescribe the drug fidaxomicin. Fidaxomicin is not that important from this group, but it has a specific use. It is having cidal action, and you can prescribe this drug in case of Clostridium difficile. It is poorly absorbed when given orally. It is usually given 200 milligram twice a day for a period of 10 days. So these are little bit about the clinical uses of macrolide group of antibiotics. Adverse drug reactions are normally uncommon in case of these group of drugs. As I have mentioned, they are very well tolerated, and this is extremely rare. Allergic reactions are always been there, like in case of any other drug, and cholestatic hepatitis or jaundice may be seen with estolate salt, erythromycin estolate, which is very commonly prescribed as a main salt from that group. Maculopapular rash, urticaria, fever, eosinophilia, pruritus may be associated with macrolide group of antibiotic in case of allergic reactions. Drug interactions are not uncommon with this group of drugs, as they are having interference with cytochrome P450 system, mediated metabolism of drugs like carbamazepine, corticosteroid, cyclosporine, digoxin, theophylline, and warfarin, and therefore it's raising their plasma levels. That means this macrolide group of drugs are basically enzyme inhibitors. These drug interactions are mainly common with erythromycin and clarithromycin because of their structural similarity. Drug interactions are mostly absent with erythromycin, which is structurally different from rest of the antibiotics, but in case of COVID-19, when people prescribed hydroxychloroquine with azithromycin, they have seen this drug interaction where patient might be suffering from prolonged QT interval. So you cannot tell that this one is particularly uncommon with azithromycin. Telethromycin is basically the first ketolide to be approved for clinical use. It has its own spectrum. It covers streptopygian, streptopneumoniae, Staph aureus, Haemophilus influenzae, Moraxella, Mycoplasma, H. pylori, Toxoplasma gondii. So this action is, the range is pretty extended one. Like most of the macrolides, it will interact with the same ribosomal protein, and it's almost having similar mechanism of action. Many macrolide resistant strains are susceptible to ketolides. Why? Because the structural modification, presence of 3 keto group of these compounds, renders them less susceptible to the efflux pump mediated bacterial resistance. Telethromycin is indicated for the treatment of acute bacterial sinusitis, acute bacterial exacerbations of chronic bronchitis, and community acquired pneumonia caused by the organisms which I mentioned before. The dose of telethromycin is around 800 milligram every 24 hours for 5 days for the treatment of those conditions, and it is usually continued 7 to 10 days for the treatment of community acquired pneumonia. A single daily dose of telethromycin is possible due to its longer duration of action. The adverse drug reactions are more common with telethromycin, showing diarrhea, nausea, vomiting. Visual disturbances are also common, like blurred vision. And the most common visual change is slowing of the ability to accommodate and to release accommodation. Exacerbations of myasthenia gravis, including life-threatening acute respiratory failure, have been reported in patients with this disorder and who have been treated with telethromycin. The other important adverse effects like hepatic dysfunction, prolongation of QT interval, and it's ultimately leading to ventricular arrhythmia, inhibition of cytochrome P453A4 hepatic enzyme, causing a number of drug interactions with cisapride, pimozide, atorvastatin, and other statins, which are also the substrates for the metabolism of CYP3A4 and whose serum level are increased because of the interaction. So these drug interaction, which I forget to mention with macrolide, is common except azithromycin, and they are showing this interaction with the statin drugs, which are basically hypolipidemic drugs in nature. Clindamycin, which is not belonging to macrolide, but it's a lincosamide group of drug, and it's a derivative of lincomycin. Both clindamycin and lincomycin have similar kind of action like those macrolides. They are protein synthesis inhibitors, primarily a bacteriostatic one, and binding to 50S rRNA. Their spectrum of activity is little bit different in comparison to this macrolide group. They are specifically active against the anaerobic organism as well as against the gram-negative aerobic organism. So its spectrum on gram-negative organism is better than any drug from the group of macrolides. It's well absorbed from the GI tract. Absorption is delayed but not decreased in presence of food. It is widely distributed. It enters most of the body compartments and achieves adequate concentration in the lungs and liver. It is metabolized to the bacteriologically active N-methyl and sulfoxide derivatives, which are excreted in the urine and bile. It is clinically used in skin and soft tissue infections, in case of dental infection, in serious infections caused by anaerobic organisms where you cannot prescribe metronidazole. You can replace metronidazole by giving clindamycin. You may have heard the drug interaction between metronidazole and ethyl alcohol. In those cases, you can always replace metronidazole with clindamycin if the previous drug metronidazole was prescribed to tackle a dental infection or to tackle any anaerobic infection. In case of serious staphylococcal or pneumococcal or streptococcal respiratory infection, including aspiration pneumonia, it can be useful as alternative to cotrimoxazole for moderate to severe pneumocystis xerovasy pneumonia in HIV infected patients. It is given with chloroquine and is effective and well tolerated in treating malaria caused by Plasmodium falciparum. It can be given in a topical form, twice daily formulation in acne vulgaris. Azithromycin also can be given in case of acne vulgaris or pimples, but it is given in the oral form, the form of pulse therapy, and usually 3 days in a week is selected, and every the same 3 days repeated for 1 to 2 months in case of azithromycin, whereas clindamycin is given mostly in the topical form. The main problem or adverse effect with clindamycin is pseudomembranous enterocolitis, which is characterized by bloody diarrhea, which I have discussed previously in relation to the other broad spectrum antibiotics as well as in the introduction of the antibiotics. It is characterized by abdominal pain, diarrhea, fever, mucus, and blood in the stools. And to treat this condition, pseudomembranous enterocolitis, you have to give metronidazole. If metronidazole is not sufficient to tackle the situation, then you have to prescribe drug like vancomycin, which is basically acting on cell wall synthesis of the bacteria. The next one, please. So, like my previous slide, I am also presentation. I am ending my discussion on the macrolide group of antibiotics with a clinical case study. Think about it with a clear vision in mind and try to find out the answer on your own. A person aged around 30 years consults his family physician for complaints of fever, cough, brownish red sputum, chest discomfort, feeling of exhaustiveness, and dyspnea. He had a history of catching cold with rhinitis and associated features 3 days earlier while on travel. What could be the symptoms accounted for? What would be the drugs most commonly used for his condition? What are the possible complications the patient is likely to suffer from if not adequately treated? And what are the common adverse drug reactions of this group of drugs? So thank you very much for the last part of protein synthesis inhibitors. You have heard it patiently and kindly concentrate on this case study and prepare for your exam on this topic. Thank you once more.